Good afternoon. My name is Inez Ponce, and I am the director here at the UCLA Center for Health Policy Research. Thanks for joining. At UCLA, we pay respect to the Gabrielino Tongva peoples as the traditional land caretakers of Tovanger, the Los Angeles Basin and South Channel Islands. November is American Indian and Alaska Native Heritage Month, and today's online seminar is aptly focused on overcoming invisibility, better health data for American Indians and Alaska Natives. An estimated 6 to 7 million American Indians and Alaska Natives live in the United States, but they are often underrepresented and even invisible in health data and research. The lack of clear data and the challenges in accessing it make it difficult for researchers and policymakers to understand the health challenges faced by AIAN communities. The data that will be represented today are particularly timely because, according to the Centers for Disease Control and Prevention, American Indians and Alaska Natives have COVID-19 infection rates that are 2 to 3 times higher than non-Hispanic whites. They also have higher rates of chronic health conditions such as cardiovascular disease, diabetes, and obesity, as well as high uninsured rates. More data and better access to it will enable researchers and policymakers to understand and determine the needs of this population. In most national population-based surveys, AIANs are often put in a residual other category or depicted as single race, non-Latino AIANs, despite fewer than 2 in 5 AIANs reporting as single race, non-Latino AIANs. So individuals who identify as American Indian Alaska Native are likely to also self-identify as another race, and drawing conclusions on data based on single race American Indians Alaska Natives fails to capture the considerable segment of the AIAN population that comprises of individuals of more than one race. American Indians Alaska Natives are also more likely to identify with Latino ethnicity than other racial groups, but most data systems report estimates only for non-Latino American Indians Alaska Natives. So today, my colleagues, Drs. Tara Becker and Riti Shimkata, researchers here at the Center for Health Policy Research, will share findings from our newly released policy brief that looked at American Indian Alaska Native data availability and the variations in estimates due to differences in coding and tabulating from 8 large population health surveys. They will discuss implications of the limited accessibility of the AIAN information in population data sets. As always, today's slides are available on our website, or they can be requested from our communications department at the email address shown on your screen. Next slide. I'd also like to invite you to join us for our Addressing Health Equity Through Data Disaggregation workshop series. Our next workshop, User Experience Accessing Disaggregated Racial Ethnic Data, will be held this Wednesday, November 18th at 10 a.m. Pacific time. I will also be presenting tomorrow, November 17th at 10 a.m. Pacific time at the Centers for Disease Control and Prevention on the topic, similar topic on improving data capacity for American Indians and Alaska Natives. In addition to today's presenters, Drs. Becker and Shimkata, I'd like to thank the rest of the project team, Dr. Susan Babby, Dr. AJ Scheitler, Dr. Sung-Hee Lee, as well as our project funder, the U.S. Office of the Assistant Secretary for Planning and Evaluation, who made this important work possible. So let's begin today's discussion.
Thank you, Inez, for that wonderful introduction. Moving on to the next slide on our agenda, So we're going to begin our presentation with an overview to our study on the accessibility of health data on American Indians and Alaska Natives. And we'll be calling this group AIAN for short. And then I'll be giving you then a brief description of the methods of our study. And then my colleague Tara Becker will then go over the results. And we've divided that into 3 parts. The first being findings on the accessibility of AIAN data in large population health data sets. The second will be results on how inaccessibility of these data impact findings. And third, the impact of classification on health outcome estimates. I'll then return to present some recommendations based on this work. And we've actually aimed to present recommendations for both survey leaders and researchers, with the hope that we can continue to grow and improve the body of research on AIAN health. So according to the 2019 American Community Survey, there are 5.7 million American Indians and Alaska Natives in the US. But other sources estimate this up to 6.9 million AIAN in the US based on the census. So these estimates come from the enumeration of all individuals who identify as AIAN alone or in combination with one or more race. And I'll talk about that more in a little bit. But one of the important questions we have as health researchers is, so what exactly do we know about the health of people who identify as AIAN? And to answer this question, well, we often look to large population health data sets. Next slide. So population health surveys are intended to monitor important health issues of all populations in the United States. And when populations present with disparities in health outcomes compared to other populations, these disparities data may be used to create programs and policies to address these issues. So it's a very important piece in policy. So for example, the National Health Interview Survey, or NHIS, provides estimates of health and healthcare access and is used to track and measure progress towards achieving health objectives. Now, in order to capture disparities based on race and ethnicity, well, researchers need an identification method for race and ethnicity. And the good news is that there is guidance that does exist on that. Next slide. So the U.S. Office of Management and Budget, known as the OMB, has provided guidance on the collection of race and ethnicity for federal statistics and administrative reporting for a number of decades. And it's widely used in the US across large population-based surveys. And the current OMB guidance on race and ethnicity is from its 1997 Statistical Policy Directive number 15. And you'll see on the slide that according to OMB guidance, first, race and ethnicity is based on self-identification. And basically race and ethnicity is asked via a 2-part question. And the first question asked is on ethnicity. Here, an individual is asked to denote whether they are Hispanic or Latino, or not Hispanic and Latino. And I want to pause here for a second to make note that we'll be using the term Latinx throughout this presentation to denote what OMB calls Hispanic or Latino. So after selecting ethnicity, then individuals are asked to identify their race. And so there are basically 5 minimum large categories of race according to OMB, and you'll see them on the screen here. But one of the key features of the OMB guidance is an individual can choose to report either one race or more than one race group. And so individuals who report more than one race group are classified into a multiracial category. So who are AIAN? Well, according to OMB, those who identify as American Indian or Alaska Native include persons having origins in any of the original peoples of North and South America, including Central America, and who maintain tribal affiliation or community attachment. So according to the OMB classification scheme, we see that the group that makes up all AIAN can either be single race or multi-race. And now if you recall back when I mentioned the statistics, there are about 6 to 7 million AIANs in the US. And so that group of all who will report AIN can include those who are single race or those that include, multi-race. And so the problem that we actually are reporting on here today is that nearly everything we know about AINs from large population health surveys is based on actually just one small subset of the AIN population. And that is those who report being non-Latinx, single race AIAN. And you'll see that in the box here that's in yellow. And why is that? Well, I think we'll be talking about that in this presentation, but this group, the non-Latinx AIAN single race, basically this group is what is most likely to be available in public use data files, and it's been sort of the conventional way to group and analyze AIAN data. And really the critical issue is just when we focus on this subgroup for estimates of health, that it may not be giving us the full picture of AIAN health. And the sample size of this group is obviously much smaller than when we'd be looking at the all AIAN category. So as researchers, we know that when sample sizes are small, research becomes quite challenged. So we'll be talking about that in our results. So having all AIAN data in publicly available data sets would really, obviously would increase sample sizes, and it would also increase knowledge about AIAN health in general. And because the federal OMB guidance, because of it, all of the large population health data sets that are out there do in fact collect AIAN data in such a way that would actually allow us to get a better or more complete understanding of AIAN health. And really the problem where it lies is in accessing data on all AIAN respondents. And typically now, how it stands now is obtaining data on all AIANs often means having to actually go to restricted use data sets, which can be actually a very costly and a time-consuming process to get access to restricted files. So it's actually no surprise then what is most published in the literature is based on the public use files, where single race, non-Latinx AIAN is typically what's most available. And as I've mentioned, has kind of become a common classification in studies that use population health data sets. Next slide, please. So you might ask, like, why should we want to capture AIANs that are not only single race, or why should we be interested in multi-race AIAN? Well, a key reason is that, and Ninez mentioned this already, is that, most AIANs are actually more likely than any other racial group to identify as multiracial, except for Native Hawaiians and Pacific Islanders. And to reiterate, the problem that we present here today is that in most of the public use data files, multi-race AIAN cannot be distinguished from other multiracial respondents in the data. And then you might ask, well, then why also are we interested in capturing AIANs with Latinx ethnicity? Well, AIANs are actually more likely to identify with Latinx ethnicity than any other racial group. And again, to reiterate, the issue that we're going to be presenting on is that single race non-Latinx AIAN is typically what's most available and has become a common classification. So we don't necessarily know much about those AIANs who also have Latinx ethnicity. Next slide, please. So when data sets only offer the single race non-Latinx AIAN category for public use, it really hurts our ability to capture the full picture of AIAN health. And ultimately, what we worry this means is that, improving the health of the estimated 6 to 7 million AIANs is hampered by the population data systems that obscure the full AIAN representation that's in the data sets. So moving on to the methods, and before I get into the nitty-gritty, I really want to spend some time to thank the members of our study's external review group, We had a talented membership on our external review group, which was representing both federal and non-federal organizations and agencies who had interest and expertise in survey weighting methodology and race classification of the AIAN population. Our ERG served as an external advisory body and provided consultation on our analytic methods and on our findings. And working closely with our ERG, we chose 7 federal surveys for this study and 1 state survey, which of course is our center's California Health Interview Survey. So we had a total of 8 large population data sets that we worked on. And so using these data sets, we examined then the availability of AIAN, all the AIAN categories in the public use files and the restricted use files. And then we performed analyses of a number of health and health-related outcomes for the different AIAN categories. And just wanted to make note that all the estimates reported here were weighted and missing data were imputed. So we had 3 main study questions. The first was, very simple, how accessible are data on AIAN in the 8 commonly used population health surveys that we'd identified with our ERG. The second question is, so do these files allow users to identify AIAN groups, namely the single race Latinx AIAN and the multi-race AIAN groups that currently don't really have much representation in the body of literature? And lastly, how does AIAN classification impact outcome estimates? So as mentioned previously, our ERG was critical in helping identify the 8 population health surveys we examined. And we selected these surveys based on 3 primary criteria. The first was how often were these surveys used in the published literature. The second was the uniqueness of the information contained in each of these surveys. And the third was whether or not these data sets actually collected Latinx AIAN and multi-race AIAN so that we could do the analysis. So the first 2 that are listed in this table, the Behavioral Risk Factor Surveillance System, or BRFSS, and the National Health Interview Survey, NHIS, they were basically selected based on the extensive use in the public health literature. And then we had a number of other surveys here. The 6 others were selected based on the uniqueness of their content or the focus on a specific subpopulation. For example, the Medicare Current Beneficiary Survey, or MCBS, is the primary source of information on Americans enrolled in Medicare. The National Survey of Children's Health, or NSCH, is the largest public health survey targeted specifically on children. The National Health and Nutrition Examination Survey, or NHANES, is unique for its collection of both survey and biological data. The National Survey on Drug Use and Health, or NSDA, contains data on drug use. And similarly, the Population Assessment of Tobacco and Health, or PATH, contains unique information on tobacco use. And lastly, we use the California Health Interview Survey, or CHIS, as it is the largest continuously collected state health survey. So I will now hand over the presentation to Tara, who will give you a summary of our findings.
Hi, everyone. Okay, so first we're going to look at our ability to identify AIANs in these data sets. Oops. Only 2 of the surveys allow users to identify all of the AIN subgroups in their public use files, but even here there are caveats. In BRFSS, it's only possible to do this until 2012. Beginning with their 2013 data, their detailed race measure that lists all the reported races for multiracial individuals is no longer available. So this makes it impossible to identify multiracial AIAN in the public use data files. In CHIS, the measures are available in the 2-year public use file, but they aren't available in the single year files. These two surveys and also NHIS include a race-only measure that allows us to identify all single-race AIAN. And this is also true for BRFIS after 2012, when you can no longer identify multiracial AIAN. And when this measure is combined with the separate indicator for Latinx status, we can distinguish between the two single-race AIAN subgroups. NSCH also includes a race-only measure that identifies AIAN, but it's much more limited. It's only valid for a subset of states in which the AIANs makes up at least 5% of the population. So in addition to these three data sets, the three data sets, BRFSS, NHIS, and CHIS, also ask multiracial respondents which of the races they reported is the one that they most identify with or that they see as a primary race. The actual wording depends on the survey. And this measure is included in the public use data files for each of these surveys. So this measure codes both single race AIAN as well as those who are multiracial AIAN and who identify AIAN as their primary race into a single variable. And this measure can be used to identify a subset of the multiracial AIAN population, the part that most identifies as AIAN. However, we should keep in mind that the subpopulation may differ in important ways from the larger multiracial AIAN group. The only other survey in which we can identify any AIAN subgroups is NSDA. But in this survey, the only publicly available race measure groups all Latinx respondents together. So only single race, non-Latinx AIAN can be identified in the data. And none of the other 4 surveys allow users to identify any of the AIAN subgroups in their public use files. So if this information cannot be accessed in the public use files, how can we access it? Each of these surveys has a method of accessing restricted use data files that include detailed AIAN information. Access is possible in CHIS using the 2-year public use data, but if you'd like to access the single-year data files and include the AIAN information, that's only available through the CHIS Data Access Center, or the DAC. DAC access does not provide direct access to the data. Instead, users submit statistical programs or requests that are run by CHIS statisticians. And accessing the DAC requires submitting a proposal, paying a submission fee, and then paying fees for the statistician and computing time that's spent running your data analysis. However, CHIS also offers scholarships for a limited number of projects to help defray some of these costs. 5 of the surveys, BRFSS, NHIS, and NSDA, NSCH, and NHANES, can now be accessed either through the Federal Statistical Research Data Centers, or RDCs, FSRDCs, located around the country, or through the National Center for Health Statistics, RDC. Accessing an RDC requires submitting a formal proposal to NCHS, and if you're going through an FSRDC, also to the Census Bureau, undergoing a federal background check, paying fees to NCHS to access the data, and then also paying fees to the RDC for using their computers and resources. PATH data can be accessed through the ICPSR Virtual Data Enclave. And accessing the Virtual Data Enclave requires submitting a proposal, paying an annual fee based on the number of researchers who will have access to the data. But it also requires that the project PI hold a terminal degree and hold either a faculty position at a university or a research position at a research institution. So this means this data isn't available to people who are outside of, who are not researchers. AIAN information is available for MCBS in a limited access data set that is physically mailed to users upon request. But in order to get access to this data, you have to complete an application form in which you can demonstrate your ability to maintain the data on a secure server. So you need to have the computing resources to have a secure server. You also need to pay a one-time access fee as well as an annual access fee. So as we can see, each of these methods requires a significant investment of time to apply and to be approved to use the data, as well as costs that can easily run into thousands of dollars. This restricts access to only those who can afford this time and have these resources to spend. So given these difficulties, many analysts will be unable to access these restricted data sets. So what does that mean for research on American Indians and Alaska Natives? This slide shows the percent of the US population that falls in each of the AIAN subgroups that can be accessed using the public use data files. And we can see how limited this information is. In the surveys where more than one AIAN subgroup can be identified, we can see that a significant proportion of this population are not single race non-Latinx AIAN. But because this is the information that's available in the public use data files, this is the data that we're most likely to use to draw conclusions about the health of the AIAN population. And we can see how restrictive this is by comparing it to the information available in the restricted use data files, which allows the identification of all three subgroups. The size of the AIAN population varies across the surveys, ranging from 2.3% in NHANES to 3.3% of the population in NSCH. These differences are due in part to the different survey populations, as well as the different years the surveys are covering. However, we can confirm that even if you restrict these to similar populations, there are still substantial differences across the surveys. We can also see that the distribution of the AIAN subgroups substantially differs across the surveys. But there are two clear takeaways. The multiracial AIANs comprise the largest proportion of AIN, except in BRFSS. Also, that the single race non-Latinx AIAN represent only a small fraction of all AIANs. And this is true across all 8 of the surveys. So what does this mean for our understanding of the health of the AIN population? When all multiracial respondents are combined together, those AIN are excluded from the AIN population, because in most cases they can't be identified in the data without accessing the restricted data. But if they can't be identified, then they can't be included in the analysis. And because in most surveys, this group is larger than any other AIAN subgroup, excluding them from these analyses may provide a non-representative picture of AIN experiences, which can obscure insights into the health challenges that they face. The other side of this is the potential effects of having greater access to data on single race non-Latinx AIANs than other AIN. This is the group that we can most easily identify in public use data files. But this group makes up only a small fraction of the total AIAN population, as we can see here. It makes up the largest share in BRFSS, where it's over a third. However, in all of the other surveys, this group makes up less than 30% of the AIN population, with a low of 12.9% in PATH. So what does this imbalance in access mean for our understanding of the health of the AIN population? Single race non-Latinx AIN is the group that is most commonly used to draw inferences about the experience of AINs in the US. However, they constitute a small minority within the overall AIN population, and their experiences may not be representative of the experiences of all AIN. But this also has implications for public data inclusion. Relying on the subgroup means that the sample of AIANs within a survey will be much smaller than it would be if we were able to identify all of the respondents who reported as American Indian and Alaska Native. That makes it more likely that the race measures that identify AIANs will be excluded from public data because of identifiability and data disclosure concerns. So releasing measures that identify all respondents that identify as AIAN would reduce these concerns and provide a larger sample size for analysis. So to sum up, again, most public health data sets provide only limited access to measures that allow users to identify AIAN respondents. And this reduces our ability to understand the health challenges that they face. Moreover, because data on single race non-Latinx AIAN are more available, most of the insights that we have on this population are based on this subgroup. However, because high percentages of the AIAN are multiracial or Latinx, and these groups are less likely to be identifiable in the public use data files, insights that are based on the single race non-Latinx subgroup may not be representative of the larger AIAN population. So now let's take a look at the difference between these AIAN subgroups across a small number of health measures to get a better idea of the impact of excluding these groups and how the experience of single race non-Latinx AIAN differ from that of other AIAN. So based on the standard comparison between the single race non-Latinx white and non-Latinx AIAN, we can see that there's a substantial disparity in health insurance coverage within all 3 surveys. Of course, the size kind of varies across the surveys. But when we include all of the possible AIAN groups, we can see that the differences across the subgroups are often as large as those between AIANs and whites. And we can see that the Latinx AIAN population is much more likely to be uninsured than other AIAN, which leads to a higher uninsured rate among all AIAN. In addition, those whose preferred or primary race is AIAN are also more likely to be uninsured in both NHIS and BRFSS, even though there's no difference between the single race non-Latinx AIAN and multiracial AIAN. This suggests that the multiracial AIAN who primarily identify as AIAN are more likely to be uninsured than other multiracial AIAN. Turning to the percent of adults in fair or poor health, we see that large health disparities exist between single race non-Latinx white and AIAN respondents in each survey. But again, the size of the disparity varies across the surveys. The difference is especially large within CBS, which is probably unsurprising given that it's focused on Medicare beneficiaries who are more likely to be older and in fair or poor health overall. When we add the other AIAN groups, we continue to see differences between these groups. The variation across the AIAN subgroups differs across the surveys, with only small differences within BRFSS, but pretty large differences within CHIS and MCBS. The pattern of the differences across subgroups also differs somewhat across the surveys. For example, in CHIS and MCBS, multiracial AIAN were in better health than single race non-Latinx AIAN, but this was not true in NHIS or BRFSS. And often these differences have overlapping confidence intervals, so this could be due to sample selection, or at least in some cases. But this suggests that limiting accessibility of AIAN information to a small number of data sets may lead us to draw different conclusions about these differences, and we'd see if we could look at it across a wider variety of sources. Turning to measures of health conditions, we see a familiar pattern of higher rates of diabetes among single race non-Latinx AIAN than whites. And when we look across all of the groups, we see that the single race non-Latinx AIAN group actually fares worse than any of the other AIAN subgroups. So it give us a larger disparity than we would if we looked at AIANs overall. Among the exception among Medicare beneficiaries, the single race Latinx AIAN have the highest rate of diabetes, and it's much higher than any of the other groups. So the differences across the AIAN groups are smaller and less consistent across the surveys, with that exception. Though again, there were few differences across the groups in BRFSS. So finally, we also look at obesity rates, and the overall pattern here too shows the higher obesity among single race non-Latinx AIAN than among whites across all of the survey. BRFSS has the smallest disparity, while NHIS has the largest, even though both surveys cover the same populations. There are large disparities across AIAN subgroups in CHIS and in NHIS, but only small differences within BRFSS. And here too, MCBS differs from the other surveys, which may not be surprising given that it has a different underlying population. In all but MCBS, multiracial AIAN are less likely to be obese than other AIAN. And so taking all of these things together, the experience of the single race non-Latinx AIAN often differs from that of other AIAN. Sometimes they do worse, sometimes they do better. And therefore, basing our understanding of the AIAN population as a whole on this group may not be fully representing the diversity of experiences within the AIAN population. There's also substantial variation across the surveys and the differences between the AIAN subpopulations. Therefore, if all we knew about AIANs was derived from the small number of surveys that identify AIAN in public data sets, we may draw different conclusions about these populations. Remember that one of the two surveys that had access to all of these groups was BRFSS, which showed much smaller disparities across the groups than any of the other surveys. So access to detailed race and ethnicity information that allows users to identify all AIAN as well as subgroups is almost always only available in restricted data. But acquiring access to this restricted data is time-consuming and expensive, which makes conducting these analyses difficult for many potential users, especially those who don't have access to research grants. This restricts the degree to which data on AIANs can be used, as well as the information that we know about the health disparities and the policy challenges that these populations face. Without this information, it's difficult to draw attention to these disparities and to design policy interventions that can reduce them and improve the health status of AINs within the United States. So now I'm going to turn it back over to Edie, who will go over our research and data recommendations.
Thank you, Tara. And as I mentioned, we've kind of divided these up. And our first recommendation, kind of targeted to survey leaders, is to consider using oversampling some more. Basically, oversampling AIANs in their large population survey. So what is oversampling? Well, in survey methodology, oversampling involves taking a larger sample of certain populations than would otherwise be collected if random sampling were done. So these disproportionate or oversampled populations are aimed at effectively studying small groups. So really the drawback of this method is that it can be very costly, but at the end of the day, oversampling is really fundamentally the most obvious and most important way for us to improve population health data on AIAN and other small groups. So the investment in these efforts is quite key in improving AIAN data capacity. Next slide. Another recommendation aimed at survey leaders is to release pooled multi-year public use data files. So the benefit of a pooled file is that it reduces the disclosure risk that may be associated with providing more detailed race data. And a really nice example of this is how CHIS provides 2-year public use data files that include this sufficient racial and ethnic detail to be able to identify all the AIAN subgroups. So this pooling methodology, or being able to have researchers have access to pooled multi-use public files, I think is somewhat of an easy recommendation for survey leaders, and we think could help improve AIAN data capacity. Next slide. A third recommendation is to for survey leaders to include information that allows researchers to identify all AIANs. So as we mentioned, so if the sample size is too small for survey leaders to offer researchers access to any of those smaller AIAN subcategories, such as the single race Latinx, the data sets at the very least should maybe include identifiers for the overall AIAN populations, so that researchers can at least examine findings for all AIAN, and as Tara mentioned in the presentation, still have important implications for research. Next slide, please. A final recommendation is for survey leaders to find ways to reduce the cost and time for accessing restricted data sets. Especially if it's not possible to include all of the AIAN subcategories in the public use data sets. And if you remember, Tara mentioned, I mean, sometimes the cost and is quite large in being able to access the restricted files. Next slide, please. So we also have a couple of recommendations for researchers, and this one recommendation we have here is actually a very simple one, but a very important one. And it is essentially, you know, researchers should really report on how race and ethnicity is defined in their study. They should also report for what purpose they're reporting on race and ethnicity. Next slide is our second recommendation for researchers. And this one, similar to the other, but it's very, very much about being explicit in the publication or the report that a researcher is involved in being explicit about when you're analyzing data that are only on single race, non-Latinx, to make that clear, that is the only group that is, you know, that is identifiable. And basically, in other words, researchers should make note when their results pertain only to a certain population, AIAN population subgroup. Next slide. So key takeaways, basically based on the work we've presented today, we know that because of the limited accessibility of AIAN data and the conventions in reporting, researchers have tended to focus on only single race, non-Latinx AIAN. And so because of this, we're being able to obtain a complete picture of health based on solely on the publicly accessible population health data we are finding that it's not only difficult to get access to the sort of the complete picture of AIAN data and all of the subgroups, but it also quite possibly gives us an incomplete picture of AIAN data or AIAN health, sorry. So we believe that AIAN data capacity can be improved. And we think that we've got some simple actions by survey leaders and some actions by researchers that can help in improving AIAN data capacity. Next slide, please. We've got a lot of acknowledgements because we had a really wonderful team of people working on this project. And as Nina has mentioned, we'd like to acknowledge ASPE for funding this important work. And as I mentioned before, we had an external review group. And also I want to make special thank you to our 3 reviewers of the policy brief that's published today. The first is Delight Satter from the Centers for Disease Control and Prevention, Jennifer Parker from the National Center for Health Statistics, and Randall Lakey from the Department of American Indian Studies and the Luskin School of Public Affairs at UCLA. So thank you very much, and we will have a Q&A that begins now.
Thank you so much. Good afternoon, everyone. My name is Tiffany Lopes, and I'm the Director of Communications here at the UCLA Center for Health Policy Research. We're going to be going through questions from the audience today. If you haven't already, I encourage you to use the Q&A function in Zoom to ask questions. So let's get started. In thinking about how to examine health policy issues like treaty-based health agreements between the US and tribal nations, including funding to the IHS, UIOs, 638 compacts, etc., where AIAN is based on tribal citizenship/political status as opposed to racial identification, do you have recommendations for capturing this population, which may be different from AIAN populations who do not possess tribal citizenship/political status?
So I think that those are addressing 2 different issues, right? Because part of this is so those data are focused on medical or health records, right? If I'm understanding the question right, and it could be I missed something. And so the tribal affiliation is important for that particular aspect. So there are ways that these population surveys could collect tribe affiliation data. And in fact, like CHIS has in the past collected that kind of data. So that could help with identifying which portions of the population health survey respondents are actually from those communities. But in terms of this speaking to how that information would be collected in the medical records, I don't think our study is can speak to that, because we didn't actually look at how that information has been collected. So it's hard for us to say how it can be improved or changed.
Sounds good. Did you identify statewide AIAN specific population health surveys? This person says, I know tribal epidemiology centers conduct their surveys within their service area.
We didn't for this study. No, we focused, in terms of, so we were focused on population health data. And so we didn't look at specific statewide data. Part of the reason we looked at CHIS is because it has this detailed information already, and also because it is one of the largest population health, population health surveys in the country. And CHIS also it was one of the first studies of or surveys this size that collected that kind of detailed information and made that data publicly available. And so because of that, it had a big impact on the research that was done on these populations. And so that's part of why we included it. I think if when we'd done our analysis of the literature, we'd seen a lot of publications that had used that data, we would have considered including those as well.
Got it, thank you. Can you comment about the population weights for these surveys? Are the control totals based on non-Hispanic single race AIANs?
We can comment on that a bit. I would say most of these surveys don't include American Indians and Alaska Natives in their weighting process at all. The ones that do, yes, are focused on the single race, non-Latinx, American Indian and Alaska Native populations. And they draw their control totals from a variety of sources, some of which, for example, some of them use the American Community Survey, which has been criticized for undercounting this population. So that undercount could be transferred into the survey itself.
Thank you. We've got some questions about specific populations. Does your research include the Afro or Black AIAN populations?
They would fall into the multiracial AIAN group, yes.
Okay, and
we
then
don't break them out in any way from other multiracial AIAN, but they are included in that group.
And then this person asks if you're looking into or planning on making recommendations regarding collection of data on tribal affiliation.
Ninez, do you want to speak to that?
Actually, probably Ruti could, because I'm pretty sure we've discussed this a lot.
Right, and I wish I had the slide which shows how CHIS collects tribal affiliation data. But yes, and I think absolutely CHIS happens to be one of the unique surveys out there that that does ask this question, and these data are available to researchers. And I believe that data are not publicly available because of a small sample size, right, Ninez? I just want to make sure I'm not going to say that.
Not publicly available, but we can certainly think about some special use research files, if that would be helpful.
Right, so if any of you out there are interested in using CHIS, please contact us and we will, make every effort to get you to the right sources to get you data on what you're looking for.
Thank you. Everyone is pushing for data disaggregation, but in some cases you're asking for aggregated data. Can you explain?
Sure. I think that is a good point. And I think in the cases where you have sufficient respondents and sufficient data to release disaggregated AIAN data that allows you to look at these different subpopulations, I think that that's a way to go. But the issue here is that so many surveys don't include any information on this population. And so being able to release even just this broader indicator is actually improving access to some information, even if that information is limited by the fact that there are differences within that population. It still gives us more information than we have right now.
Got it. Did you assess MIHA, which is California's Maternal and Infant Health Assessment data? CDPH conducts an oversample of AIAN data.
Tiffany, I think I answered that, that we did not, it was not within our scope, but that it was, thank you, Vanessa, very important to know that there was an oversample. It gets at, again, with smaller populations, this trade-off between disclosure risk and this availability of the data. So I think oversampling was one of our recommendations And then also just on a broader comment about why insights on the American Indian Alaska Native population are not monopolized. The monopoly of federal health surveys and population surveys like CHIS, we do not hold the monopoly on the insights on American Indian Alaska Native data. But what the project was for the Department of Health and Human Services was if we were to increase then the data capacity of these federal surveys, then what would we do? So that's where the scope of work was in terms of the focus of looking at these federal surveys, as well as the California Health Interview Survey.
Thank you for clarifying, Inez. One or two more questions from the audience. If anybody else has some last questions, please submit them now. Were you able to compare location of AIAN, like urban versus rural?
Go ahead.
We did not do analyses of that, but I think all of the data sets, and Tara, you can correct me if I'm wrong, and I'm sure it's, you know, in all of these data sets, there would be an identifier of urban versus rural. Tara, is anything you want to add there?
No, I think it is definitely possible. We didn't do that here, but you can do that.
Thank you. You've outlined in your presentation that we don't have enough access to data. So what's the solution?
So I think, you know, some of it is to survey administrators to make access easier. So the process for getting into an RDC takes a really long time and is really expensive. If there are ways that, you know, even if for people who are doing research on these kinds of populations where that's the only way of studying them, you know, there may be ways to waive some of the costs, for example, to make it cheaper, or, you know, but there are also ways to make more data publicly available, either by producing this aggregated AIAN indicator for public use data files, which will dramatically lower the costs, or by pooling data and creating pooled weights that allow you to look at these populations in greater detail. So I think some of it is up to the survey administrators. Most of it is up to survey administrators. I don't know that in terms of users, that users can make that data more accessible, right? Yeah.
Right. I was going to add, and I think from the research side, we think that there are ways to improve, at least on the reporting. And when observations or, you know, analyses are done on, say, single race, non-Latinx, AIAN, to make that explicit in your publications and in your reports. I mean, we didn't present on it here today, but Ninez, I believe, will be presenting on it tomorrow, sort of a deeper dive on the literature, the published literature in PubMed, for example, that use population health data sets. And we found that, yeah, there's typically, you know, sometimes in publications, there's no mention of like how AIN was even categorized, or what specific subgroup it pertains to, or if it's everyone, all AIN, for example. So anyway, I think we can do better on the research end to at least report and be more thoughtful in our findings, or discussion of our findings that, you know, for example, maybe your results only pertain to a certain subgroup of AIAN.
Thanks. And just a reminder to the audience, I did drop in a link in the chat earlier that is the policy brief that was released today. So if you didn't see that, if you just go to healthpolicy.ucla.edu, it's the opening slide. So let's see, one more question. To all the contributors, what are your thoughts on the current discussion of data sovereignty, which is the idea that data are subject to the laws and governance structures within the nation it is collected?
I think data is supposed to reflect a population. I mean, I know as a survey leader, what we strive to do is to ensure that the data that we collect is as high fidelity as possible in reflecting an individual's affinity to a race, racial ethnic group, a tribal affiliation, a language group, and then beyond that, looking at other multiple identities of sexual orientation and gender identity, for example. So it's so I support data sovereignty because in as much as it reflects, again, all the effort in the representation of what that data is trying to purportedly provide for social action, social mobilization, policy attention, allocation of resources. Because data is about, of course, power, it's about allocation of resources. And so ensuring that data really speaks to what the needs are of the population. I think that's what we're striving for. As data advocates and as research centers and as a survey leader and producer of data. So we do support that, but again, ensure that there is always going to be the tension about disclosure risk, respecting the individual who provided that information to the data collector.
Thank you. I mean, I can't really think of a better way to end this presentation. So thank you, Ninez, and thank you to Dr. Becker and Dr. Shimkata for this thoughtful presentation. I just wanted to thank everyone in the audience for attending this month's webinar on overcoming invisibility, better health data for American Indians and Alaska Natives. We will be posting the recording of this webinar online with closed captions within the next 2 weeks. Please visit healthpolicy.ucla.edu/seminars. As a reminder, if you'd like a copy of today's presentation, please email us at healthpolicy@ucla.edu. Thank you and have a wonderful day.
Thank you. Tiffany.